Italy. Then Dror, who is the next president of EFIM, will talk about the situation in Israel, and Runolfur Palsson will talk about the situation in Iceland. So we will try to to condense all our talk in 5 minutes, 7 minutes more. And then we will start to answer the questions. So I will leave now to Alberto Marra, who is our Young Internist Chairman, the word, as he will be the moderator today.
Okay, thank you, Nicola, and congratulations for this very interesting initiative. And it's really a pleasure to me to introduce all the moderators in this so-called Meet the Presidents session regarding these unforgettable 2 months. And as you know, we in Italy were the first country in Europe to be massively involved in this outbreak. And the experience of Nicola Montano, who is head of the internal medicine department at the University of Milan in Italy, experience will be really helpful, since Milan region, Lombardia, was the most involved in this outbreak of coronavirus. So I will leave the word to Nicola soon for his presentation, and we are looking forward to hear his story.
Thank you very much. So I'm sharing my desktop, and I hope you can see. Okay, so let me briefly tell you what happened in Italy. So this is my disclosure. So, you know, the story in Italy started on February 21st. On February 21st, when we have the first case in Codogno, in the Codogno hospital. Codogno is a small town, 10,000 people living there, 32 kilometers far from Milan. And the first case was a 38-year-old man, was an executive worker, a sportsman. And he was admitted to the emergency room on February 18, so 3 days before, for dyspnea and fever. And, you know, they evidenced the presence of the bilateral interstitial pneumonia, but he did not have major problem. He didn't report any history of travels or contact with people from or coming back from one region. So he was sent back home with an antibiotic therapy. However, he went back to the emergency room the next day because of a worsening of symptoms, and he was admitted first to the internal medicine ward. And then after 2 days, he moved to the ICU for a further worsening of the respiratory function. When he was in the ICU, an intensivist tested this patient by COVID just for, let's say, he said, you know, our pre-test probability is very low, but you know, there is this COVID-19 around, let's try. And they discovered that he was positive. So, I mean, he was intubated, he stayed for 3 weeks in the ICU, and this was February 21st. On February 22nd, our government locked down 11 cities around Codogno, so a surrounding area close to Milan, and everything started from then. So the problem that we had is that when you have an epidemic, you don't want to have your first patient inside an hospital, because it means that he has been in contact with nurses, physicians, and other people. But this is what happened. So the bomb in Italy and in Codogno, Lombardy, exploded within the hospital. Then, you know, we stayed for a couple of weeks with a sort of partial confinement, but on March 5th, lockdown was extended to all countries. So we are now close to our 50 days of quarantine. So what happened in these 2 months, exactly 2 months? So this is our strategy. The most important strategy was confinement, social distancing, because at the beginning, we did not have an easy access to diagnostic testing, and was controversial whether and who to test. The contact tracing was very elusive, was made usually by phone calls of interviewing the first patients, but of course was impossible to track. And we have limited population screening in the sense that our healthcare system is divided as under regional laws. So we have, of course, the state government, the national government, who provide the general rules, but then, the organization is left to all our region. And unfortunately, in Lombardy, that has a very high standard in healthcare, unfortunately, the family medicine and was not so strong, is not so strong. And this was one of the reasons of the failure we had, because everybody got to the hospital. And so we have our hospital under very strong connection. This is how the distribution of our cases, from the clearer areas with less cases up to the areas with the purple color, which is Lombardy, and the other is another region close to Turin. So two very highly industrialized and rich area. As you can see, there is a real difference between North and South. South was very, let's say, weakly hit by the COVID, and we are happy for this. But the geographical distribution is really, really different, and still we don't understand exactly why. There are hypotheses, we don't know why. So these are our, these are our update. These are the data of yesterday. Up to yesterday, we have 180,000 cases. We are now, I think, third in the world, because I think that Spain overcame us. But the number of deaths are the highest, and we had 24,648 cases. But this is absolutely underestimated, because these are the deaths that we have in patients tested for COVID in the within the hospital. So the age, our age, you see that, I'm sorry, these are in Italian because I just took it down from our Minister of Health website a few hours ago. The age, we have 38% of patients with more than 70 years, 33%, 1/3 between 51 and 70, and below 50, 27. No kids, I mean, a very small amount of children up to 10 years has been reported, all having only a mild flu. So this is the mortality. Deceduti means dead, and this is the lethality. So you can see that the age from 70 to 90 account for almost 80% of all deaths. And but 11% of deaths was, and 15% was between 50 and 69, and we think this is very high, and it's higher than in China. However, as I told you, the mortality based on the data from the electronic digital data that we have from the hospital is absolutely underestimated. So we, we thought that to really have an idea of the impact of COVID, we should see the difference between the expected death in one territory with the actual death. And you can see here, we did this study that we submitted yesterday. You see that these are in blue, the average of deaths in the last 5 years. And you can see that, in this month, they have been around, between 5,500 and 5,000, quite consistent in the last 5 years in Italy. But you can see that the increase is really dramatic, and we pass, for instance, in the third week of March from 4,100 to 1,100 to almost 11,000. So an increase of 238% of the death in 1 week. So we believe that this is a better way to study the impact of COVID, just looking at the average mortality over a longer period and compare with the actual mortality. And you can see that the mortality is very high, much higher than what has been reported in the digital record. I finish, and I would like here to underline the tribute. I would like to provide a tribute to the healthcare workers, because we had very high mortality in Italy. So far, 131 physicians died, 31 nurses died, and around 18,000 healthcare workers have been infected. We are the professional category that so far has been more infected. The tribute is very high that we paid. Out of 131 physicians, half of them were family physicians who at the beginning were just, sent without the appropriate personal protective tools. And so we paid a high tribute. We are entering now a phase 2. We are in a plateau. We still don't know exactly what is the level of infection in the general population, because still we haven't yet started a screening in terms of antibodies together with swab testing. So we are still looking, mostly in Lombardy. This is in Lombardy. In other regions like Veneto, Emilia-Romagna, or the South, the situation is much more controlled, and I think that in a couple of weeks they will just weaken a little bit the lockdown. We are still waiting for having data, real solid data, to decide the strategy to follow. Okay, thank you very much. And I think that we are looking for the next normal. Normality will not be what was in the past, but we have to create a new normality. So thanks, and I will leave the word now to our moderator for the next.
Thank you, Nicola.
I don't know whether some of you want to ask questions just related to the Italian situation. Otherwise, we will leave the question for the end.
Okay. So I will collect eventually some question for Nicola from Italy. And now, so I recall you also the message to mute your microphone and eventually send your question to me. Now it's a pleasure to introduce also Professor Dror, who is the head of Internal Medicine Department and Obesity Clinic at the Ashram Hospital Rabin Medical Center, Tel Aviv, and now is also leading the COVID department at the same hospital, and is also the elected president of EFIM. And he will tell us something more about the COVID outbreak in Israel. So, Dror, we are looking forward also to hear your talk.
Thank you, Alberto. Do you hear me?
Sure.
Okay, thank you, Nicola, for this very important, very moving presentation. We all share your losses, and please accept our condolences. So, the epidemic started in Israel in day after the election, in the 3rd of December and 3rd of March. And you can see here, I'm sorry that it's in Hebrew, but as Nicola said, we took it from the Ministry of Health. You can see here the difficult cases, and here are the severe cases, and here are the death. And you can see, as in all countries, the very severe cases is rising up until yesterday. But in a very optimistic way, we can see the flattening of the curve and even decrease in the severe cases. If you want to look it's in more close, you can see that a little bit optimistic way to see that those who are ventilated, the number of ventilated patients are reducing in Israel. As in Italy, we had 2 weeks of totally lockdown, and in the last week, the lockdown is a little bit released, and we hope this release of the lockdown is not contributing to more cases of the severe disease. What we can see here, again, apologize for the Hebrew, is that if you look on the ages and the signs of COVID-19 by age, in the age between 50 to 60 and in the age between 70 to 79, people come with fever and signs of respiratory difficulties. These are the most frequent signs in this age group, and in this age group, it's the most frequent signs, fever and respiratory difficulties. Now we can see the distributed by age. Again, you can see most of the infected patients are in the younger age, between 20 to 29, and in the elderly age, there is less amount of people with a COVID. But if you look on the severe diseases, and you can see here the ages, and these are the numbers or percentage of patients with severe disease, you can see that most of the severe disease come from the elderly group. So they have less frequent disease, but more severe disease in this group age, as Nicola showed us. If you look on the mortality, you can see again, the mortality is increasing steeply in the elderly ages, and we have only 10% in the age of 18 and above, around 5% of mortality between 70 to 79, and 2.5% of mortality between 60 to 69, much less than China, Italy, and other countries. And we think the reason is that we had the time to prepare ourselves, and the other reason is that we have very early lockdown from other countries. We canceled flights from China and from Europe, and by doing so, we isolated ourselves from the outsides. The problem now is that we have two major source of diseases. We have major source in old age homes, which is reflected in these numbers, and the other source is in very concentrated community of the Orthodox Jews that live in very concentrated, very nearby communities that are not really isolated. So these major eruptions nowadays are coming from these two sources. If we want to look on the numbers from Israel, is that until today we have more than 14,000 positive cases, but this is a false numbers because we don't know the denominator. So it's 14,000 from what? So I don't really trust this number. We have 500 hospitalized patients, and in Israel, the moderate severe patients are hospitalized. The non-moderate, meaning the mild disease, are sent to hotels, special hotels that we built for these mild cases of COVID-19. The moderates and the severe are sent to hospitalized, and we have 500 that represent 3.5% of all cases. 111 patients are mechanical ventilated in all the country, and recovered until now nearly 5,000. We use several pharmacotherapy, but we really try to start every patient to put, we want to put every patient in a study that in the end of this epidemic, we will have answers what is the most effective treatment and what are the ineffective treatment. So we use hydroxychloroquine with or without azithromycin. We use taclizumab. We also use remdesivir, and we use convalescence plasma. Until today, we have 188 deaths. Again, 1.1%, which luckily is a very low number due to all our emergency action before the virus came to Israel. In my internal medicine, we had, until we did this statistics, we had 63 patients. Our internal medicine are also treating mechanical ventilated patients. In every internal medicine in Israel, we are treating mechanical ventilated patients, and we have 6 to 8 beds to treat those patients. So we had 5 patients that we ventilated by mechanical, and it's 8%. We have 3 mortalities from the ventilated patients, and 2 became moderate, and we succeeded to win them from the mechanical ventilation, which were very big success. We have 22% of moderate patients and 70% of mild patients. So when we started to build our department, so the most important thing for me was to protect my staff. And we had 2 rules: less frequent entrance to the department, and blood test and x-ray only if necessary. So this is totally different medicine that we were used to, and we really tried to keep these rules. Unfortunately, when you treat mechanical ventilated patients, you can't really do these rules, because we have to be there much more time than we planned. So we built our system by telemedicine. We sat in another building and saw our patients through the teleconference system, and we really treat them by telemedicine. And this is new for me, because as internist, I used to touch and to feel the patient and to see his eyes and to see his skin color. And I didn't have these tools because we had to speak and to examine the patients only by voice and see. And this is totally new for us. And then we had to be a super clinician to really understand what happens to the patients without really examining them. As I told you before, we also had 6 beds for mechanical ventilated patients. And for these patients, we had much more work to do in order to treat them. And this is a new way to treat them, and really another lecture how to treat those mechanical ventilated patients. This was very exciting for us because it's a new science. We really learned from the Italian, from the Spanish, from the Chinese, how to treat, and we implement the positive things into our daily work. And we also learn from our work what to do and what not to do. 40% of our patients were diabetes. And this was a big challenge because we had to treat the diabetic patient from far. So we had several rules. We stopped metformin and SGLT2 inhibitor. We targeted the blood glucose between 140 and 180, and we used basal bolus system. In some patients that didn't have very high level of glucose, we used basal insulin and DPP-4 inhibitors. And those, of course, for type 1 or type 2, we used what we called freestyle Libra or other sensors that we could read the glucose level from outside and not from inside. So just to show you how we did it for... It's in Hebrew, so this Libra we put in every patient. Okay, so we measure in the Libra, through the Libra, all the glucose levels, and we can really control from outside most of the diabetic patients. So thank you for listening, and we hope to meet you in a much better arena and much better days. Thank you.
Thank you, Dror, for your very interesting presentation and also your perspective of telemedicine that I guess it will involve us in the future. And now I'm really glad to introduce you Runolfur Palsson, who is the past president of EFIM. Runolfur is head of the nephrology and internal medicine at Landspitali in Reykjavik, University of Reykjavik. And we are also looking forward to hear what happened also in Iceland. Runolfur.
Thank you, Alberto, and good afternoon, everybody. I hope you can hear me well.
Yes.
Now, as you know, Iceland is an island, and it's small, particularly small population of 364,000. So I would like you to bear that in mind as we go along. Well, we began to prepare when the news broke from Wuhan, China, and we began to test the travelers coming to the country in early February. But the first cases were diagnosed at the end of February 28th, and those were ski travelers coming from northern Italy, and then a little bit later on from Austria. And immediately we began comprehensive strategies run by the Department of Civil Protection, Emergency Management, and then the Directorate of Health, which is the chief physician's office in the country, basically recommending self-isolation to groups of people that we consider very high risk, and then quarantining those who had been exposed, and then social distancing measures. And later on, we moved to prohibiting group gatherings, closing down schools and so on. We had easy access to diagnostic testing based on symptoms and exposure early on. And then when Decode Genetics, our genetic institute here in Iceland, began to test, actually with the goal of studying the viral genome, then testing became widely available, and I will get to that a little bit later. Then we had put a lot of efforts into comprehensive contact tracing with a large group of people doing that, and later on population screening as well. Now, this is an app was generated for the contact tracing, and that works very well. Now, in terms of care of the patient, the University Hospital in Reykjavik, actually my internal medicine department assumed the responsibility to organize the care across the country in collaboration with primary health services and other hospitals. Now, we monitored in a similar manner as Dror described. We closely monitored everybody who was diagnosed with the infection, who were in isolation, obviously, by using telehealth services, and both monitoring symptoms and also and assessing risk and supporting the implementation of stringent isolation. So monitoring the sort of the household as well. We also generated an app for clinical monitoring where individuals can actually enter their information online. Now, patients with worsening symptoms were referred to an urgent care clinic that we launched. And then finally, those who could not really be isolated from their family members, we used hotel accommodation for those. Now, the number of cases is shown here. Actually, the blue bars are, viral tests done at the hospital virology lab, and then the orange-colored bars by Decode Genetics, and you can see the distribution is fading down when it. So basically, it's flattened out in the middle of April, and in the past few days we've had only a handful of cases. The majority of individuals have already recovered. Now, just to take you through the sort of the outcomes, and we have done a lot of testing. We tested 44,000 people already out of the 364,000. The number of cases to date is 839, which is 0.5% of the population. We've had 102 hospitalizations, which is 5.5% of cases. 27 ICU admissions, which is 1.5% of cases. 15 required mechanical ventilation, and 10 of those have already recovered and come off the ventilator. There are 3 still on a ventilator, 2 have died. We used hydroxychloroquine and azithromycin in 45 patients and tocilizumab in 23 patients in the ICU. And we've had 10 deaths, which is 0.5% of cases. Now, we've been lucky because the age distribution, we've been able to protect the very elderly in nursing homes and so on. So the majority of patients have been, between ages of 30 and 70. The hospitalized patients have largely been between 50 and 70 years old. And we've had no healthcare worker become infected on the job. Those healthcare workers, physicians and nurses that have gotten the infection were ski travelers that actually returned from Italy. So we, in terms of personal protection equipment, I mean, things have been fine here. And finally, I want to share with you an article that appeared in the New England Journal of Medicine this week from the group at Decode Genetics, where they did population screening in Iceland, and on random population screening of 2,300 individuals, 0.6% had a positive test. Of course, we know that the sensitivity of the test is far from 100%, but still in the community, we know that only a small fraction of people have the infection. The female-male ratio in Iceland is 0.68. So predominantly males, and we are now doing antibody testing. So I'm going to stop here. I'm sorry about the slides, but I think you have all the pertinent information regarding the Icelandic experience. Thank you.
Okay, thank you, Runolfur. You did a great job. So now I would like to start with some questions that were collected by Anita during the week, and also there are a couple also of questions coming from the audience. So I will start from the very first one, and it was also a sort of small discussion and data sharing in the chat. during the presentation. So this is a question coming from the UK. The data shows that males are more likely to be severely affected by COVID-19. For example, UK data so far shows that of the COVID-19 patients ventilated in ICU, 83% are male. What explanation are there for this phenomenon?
May I answer? May I try to answer?
Sure.
So far there are different hypotheses. The weakest hypothesis is in my opinion, is that women has an immune system that is more efficient than males. From one side, this could be, even because in our autoimmune disease cohort, we are seeing a very mild disease, even in those not using corticosteroids or immunosuppressant. So this is one hypothesis. The other one that should be tested is that males have much more comorbidities than females. So, you know, they have much more cardiovascular diseases, cardiometabolic disturbances. And so this is maybe one of the reasons why the females are more in fact, the disease is more severe. Then, you know, there's also have been also reports saying that the ACE2 receptors are more expressed in male than females, but these are very limited studies. So we still don't have evidence. There are hypotheses.
Yeah, but clearly, based on the Icelandic screening, you know, study, females contract the virus less than males. So somehow you know, they are, you know, less prone to actually get the infection. So that's interesting.
Yeah. No, Ron, but in our experience, you know, in general, in Italy, we have 52% of males and 48. But if we look at the mortality is for 2/3 of male and 1/3 of female, correcting also for age, because females are older than males. So one possibility at the end, where we'll have all the clinical data, maybe, you know, we will be able to see whether are the comorbidities or other drugs. We don't know.
So our experience is that women are much less affected than men in the elderly ages, but they had higher mortality rate than male in the elderly. So women had higher mortality than men. I think the ACE hypothesis is very interesting because in animal studies, there is effect of estrogens on ACE2. And the effect of estrogen on ACE2 really protects the women compared to male. If you give high fat diet to male animals, so you see higher ACE2 receptors and higher hypertension. And maybe this is the explanation why there are less sick in COVID-19, but the higher mortality in the elderly age. So I think that the explanation will come from the ACE2 receptor and the relation to estrogens.
Yeah, but you know, there may be also some ethnicity because, you know, we saw a different, you know, the mortality in the elderly is much worse in the male than in female. So maybe there's also factors that are environmental factors, ethnic factors that may
smoking.
affect.
What do you think about smoking, Nicola?
Smoking also, that is much more it's much more in male than females, of course. Of course. You are mute.
Yeah, I'm mute. Sorry. I will jump to another topic that was also addressed in the chat discussion, and it's about the use of ACE inhibitors and RB blockers in patients with hypertension. And what's your experience first? What do you think should be done? And what about the future of this therapy, and which group of antihypertensive drug could be the more appropriate?
Well, I can inform you that we have a national prescription database, and we started to look at this issue with renin-angiotensin system blockers, and really so far haven't really seen any association with getting the infection or worse outcome, although we have a small cohort of patients, of course. But I mean, I think it's very important when you address this issue is to first of all, obviously look at the evidence, which is very limited regarding this, and then look at two scales, and you weigh the potential benefit of these treatments for the patients that are taking the medications, as opposed to removing them because of a very limited notion that this may actually have something to do with contracting the infection. So we left everybody on these treatments.
Yeah, so the recommendation of all the guidelines is to keep on taking them. But I have to say that as a clinician, when the patients come to me with a moderate or severe disease and the blood pressure is low, so it's much easier for me to stop the ACE and ARB.
Yeah,
So
of course.
I don't have to really think about it, but the physiology behind this is very, very interesting. If you take the angiotensin receptor blockers, so you think if you block the ACE1 receptor, so all the angiotensin will go to the ACE2 receptor, and then will really prevent the virus to react to the ACE2. But there is another possibility that you increase the ACE2 receptor, the number of the ACE2 receptor, and you increase the virus. So it's very complicated. On the other hand, if you take ACE inhibitors, so you decrease the ACE1 to 7 that improve blood vessels. So I think it's a very, very complicated, and I'm not sure that we will have an answer. And
I agree. It's very difficult. And also, the evidence started from in a reverse way, because ACE inhibitors are the most prescribed drugs for hypertension and for any kind of patients with cardiac diseases. So at the beginning, it was like, when at the beginning they said that the anti-inflammatory, the non-steroidal anti-inflammatory were associated with a higher mortality. That was exactly the opposite. The fact is that the patient with the worst infection did not respond to acetaminophen. So we were using even non-steroidal anti-inflammatory, and then many of them shifted, but because the natural course of the disease was shifting. So it was the opposite, where they were the more severe patients. So even here, there are hypotheses, but still no evidence.
Sure.
At the Sacco Hospital, which is the Italian hospital with so far treated most patients, more than 700, they have just submitted a paper in which they describe that there is no any negative effect of ACE inhibitors or RAS inhibitors. So, but this is still something ongoing.
Yeah, I may say that it's a very important question, and I will link also to another very hot and burning topic, which is about the data on pulmonary embolism as contributing factor to the outcome of these patients. And do you agree with that? And are you indeed looking for emboli on a big scale and treating them?
I don't know. I can start.
Yeah.
We are, I have never believed that there is, only one there is a primum movens, or there is one mechanism that is more involved than other in this cascade induced by the corona. Recently, I reviewed a lot of papers dealing with the epidemic of H1N1 influenza in 2015. And if you review them, you see that they describe exactly the same cascade and the same side effects of corona. And all the intensive, the critical care papers are dealing with the description of massive pulmonary embolies, providing the death, or a lot of intravascular disseminated coagulopathy or vasculitis, exactly the same. So we have to, we don't have to focus on one single mechanism, on different mechanisms. I've always told my collaborators not to push too much on anticoagulation, but to refer to the clinical data, to the dimer levels, to the fact that you have patient with comorbidities that maybe is confined to bed, respect to the youngest and not confined. I don't believe it. Now, at least in Italy, the phenotype of patient is completely changing. Now we are seeing that the patients who are coming to the hospital are less severe, much less severe, but now we are recording now the side effects of a quite strong anticoagulation. And we are recording a lot of hemorrhagic situation now.
If I may add to this, I completely agree. I mean, we have been looking, particularly in patients with severe hypoxemia, where the CT scan didn't really look that impressive. So on top of that, I mean, we've been looking for obviously, pulmonary embolism, and haven't really found any cases. I was reading about the description about the Spanish flu in 1918, and I'm not sure if you have done that, but what was really impressive in that epidemic is that individuals who died, they died frequently from hemorrhage, lung hemorrhage and hemorrhage from different sites. So I'm really wary of pushing anticoagulation when you don't really have a proof of pulmonary embolism in the cases of COVID-19.
Yeah, but I want to present the other side. Well, in this study, in this disease, we saw patients with 100,000 D-dimer. And those who are on mechanical ventilation, we are giving them anticoagulation, full anticoagulation. We saw cases with pulmonary M that we treated with TPA, because suddenly you start to see the patients that were okay on mechanical ventilation that start to deteriorate and to be hypoxic on mechanical ventilation, and the reason in most of cases are PE. So I think we have to divide between the moderate and the severe patients. The severe patients with high D-dimer, I would give a full dose anticoagulation.
Sure, but it depends, as I told you, it depends on the clinic, not
Yes.
from, everybody, all the patient on anticoagulation.
Absolutely.
Because this, now there is a lot of people that supporting this idea.
Yeah, because these elderly patients takes also aspirin or microprin and Plavix and other stuff that really promote bleeding. So we have to be very careful. But those who have very high D-dimer, I think those should get full anticoagulation.
Yeah, but the thing is about this this pandemic is that there's a lot of efforts that have been done and different treatments and so on that is really mostly based on sort of circumstantial evidence, unfortunately.
Yes.
Still, the paper, the JAMA paper on April 13, in which they said that no treatment evidence so far. So we are trying to get from our experience. So we don't, from one side, we would like to find out the Holy Grail to solve any problem, but it would be difficult. And we, as an internist, we know that everything is much more complex because infectivologists would like to use antiviral. Hematologists would like to use anticoagulants. So, but we have to you know, try to integrate,
Yeah.
because we know that it's complex.
Yes, and another complex scenario is the one that was addressed by one of the attendee, and I think also Runolfur maybe can give us some suggestion. And it's about, what about infected dialysis patients? Any experience of treatment?
Well, in Iceland, I mean, we were able to, fortunately, so far, escape, you know, COVID-19 in the dialysis population. We had one individual with a kidney transplant who became very ill and ended up dying, but that individual had major comorbidities as well. Now, in terms of the dialysis patients, I mean, we isolate them and we divided the staff so that, you know, in order to protect the staff as well. And fortunately, there was no infection. We know from Spain and Italy that the mortality rate in the dialysis population is quite high, you know, ranging from, you know, 17 to 25% or so. And the same applies, although a little bit lower, to the transplant population. But I think when you look more closely at those individuals that from these populations that do not survive, is that most of them are either elderly or have major comorbidities as well.
Yeah, it's a really problem. We have 3 patients like this, one in my hospital, in another 3 in other hospitals. One is mechanical ventilated in a very severe situation. In the department, we have a patient with a transplant kidney, and it's really a challenge because you have to reduce the anti-rejection medication, because you really reduce his immunity if you give all the anti-rejection medication. And if you want to give hydroxychloroquine and azathioprine, so you have to reduce the level of the dosage because all the other medications. So it's really a challenge, and they are very difficult patients. What we did, we give him chloroquine and azithromycin, and we reduce his anti-rejection medication. His fever lasts for 15 days until he recovered. So you have to be very patient with him.
Hydroxychloroquine is another chapter that is still,
Yeah.
you know.
Yeah.
I have to tell you, I using at the beginning, but I was really skeptical because I didn't find any evidence. There was a French study that was not randomized, was based on 20 cases, and that was the one used to treat. But it was not, that was not supported by any evidence. Now, yesterday, I saw the preview, still not published, the preliminary data of a study that they are doing in Montefiore, New York. And it's a randomized study, very nice study, in which they had 3 arms, hydroxychloroquine plus alone, hydroxychloroquine plus azithromycin, and nothing. And hydroxychloroquine seems to be associated with a significant increase in mortality. And there is no bias of selection. So still, in my opinion, it's you know,
Nicola, it's a retrospective study. It's not fair study, because if you look into the groups, you will see that those who didn't receive hydroxychloroquine had much milder disease. They came to the hospital. Most of them came to the hospital with a saturation of above 33.
No, yeah, I'm sorry. I said that, no, there is the bias, but the problem remains. Still, the problem remains. You know, the evidence.
No,
there is no evidence.
It's true.
No evidence.
I agree, but my experience, the combination of azithromycin and chloroquine is better than nothing. So this is my experience. It's interesting what Runolfur experienced, because they also treat like this.
May I point out something that Nicola, I want to repercuss what Nicola said earlier, we have also seen in the last couple of weeks much milder cases than early on.
Yep.
Is that the common experience? I'm really interested in knowing that, because everybody now we are lifting off to some extent some of the social measures very sort of slowly, but people are worried about a second wave or a third wave of this. But if it's much milder, I mean, you know, going back to the Spanish flu, that started off mild and then became horrendous eventually. Hopefully it will be the other way around with COVID-19.
We are really seeing a difference in the phenotype of the patients. It's completely different from the beginning. You know, at the beginning, we have a lot of young between 40 and 60, many of them, you know, and even without any comorbidities. Now we are older, more female, milder, very few severe. So we are not understanding whether it's the virulence of the virus that is changed. Someone say that it depends on the season and depends on the average temperature. We don't know, but the phenotype is completely changing, and our intensive care now are freely a lot of free beds, like the semi-respiratory, semi-intensive cares. So it's really changing. We don't know what's happening.
Runolfur, do you have experience with the combination of azithromycin and chloroquine?
Well, we are doing many studies on our you know, COVID-19 cohort, and including obviously this retrospective analysis of the treatments. So but I don't have the, you know, I haven't really looked into it. I have my doubts, I must say.
Yeah, I think that maybe in the next, you know, in June, July, we will have some good data, and you know, to really to reflect on with some evidence.
We will have the solidarity. Did anyone?
The solidarity and a lot of other the randomized control trial, because now we need randomized control trial.
Nicola,
Otherwise, we can use even vitamin C.
I see there is a question on steroids. So,
yeah, there was a question about steroids, BCG vaccination, and biologic treatment. So maybe if you can give us an overview of your idea.
Do you want to start, Nicola? Or I will
Start.
So our experience with the steroids is like this. So in the ICU, they give Solmadrol for everyone. We are measuring IP10 and the trail. So IP10 is the part of the interferon gamma tract, and trail is part of the IL-6. So those who have a high IP10, meaning have high viral disease, so we are giving them Solmadrol, and we saw very good results. Those who has low IP10, so we don't give them. Regarding vitamin D, I don't have any experience. Regarding anti-IL-6, again, we started to give the anti-IL-6 when the patient were intubated and mechanical ventilation. This stage is too late, even though those who receive the anti-IL-6 seems to us that improved a little bit, but two have candidemia, and one yesterday have perforation of the intestine, which is the side effects of the anti-IL-6. So you have to be very careful. We start to give them much earlier now when they come with pneumonitis, severe pneumonitis, and we will see. But in a very first opinion or first impression is that it might help. What is your experience, Nicola?
We have the same experience for corticosteroids, the same, absolutely. And even for the tocilizumab, for the anti-IL-6, I would say the same. You know, even our critical care intensivists, they say that really is difficult. What it's quite, now they are doing a study here in Naples, I think. What they say is that when they respond to tocilizumab, they respond very fast.
Yes.
You know, they, for instance, they were there, you know, in the intensive care unit, the incubator for 10 days, and they provided, and in 2 days, they shifted. So there is some, you know, the problem is that, as you said, these drugs are associated with a long-term immunosuppression. So we still don't know the side effects of this. It may help because from a pathophysiological point of view, we know that we have cytokine storms. Maybe it would be better to use some modulator. We started with apremilast, with the modulator of cytokine used in psoriatic arthritis, but we have collected 10 cases, so it's too early to say. Too early.
Yes.
And for the no experience with the vaccine, no experience. And even for the vitamin D, no experience.
And so after speaking about therapy, I would like to cluster some question about some healthcare strategies. For instance, if an app to install on your mobile can be helpful in alleviating the strict social distancing, if eventually public transport system will be more accessible, and how we can conduct human behavior and maintaining distancing, or do we need other measures? And this is a very $1 million question. How do you think we can prevent a second wave in our countries?
We have to be robust. I mean, I think if you look at the Icelandic experience, I mean, of course, we are small and we are isolated, but you can take any, you know, similar sized population in any country that is being managed by local healthcare institutions. And, you know, you should be able to organize ways to deal with this. Of course, the human behavior issue is the most difficult one, but I think we have to, you know, in preparation for future epidemics, let alone pandemics. I mean, I think we have to use these kind of measures, and I think using electronic or digital technology, apps, you know, telephone apps and so on. I mean, there are many, you know, great opportunities and avenues that we can explore. And I think here in Iceland, I mean, the telephone app for contact tracing, telephone app for communication with patients, using, you know, this type of electronic communication to not only monitor symptoms, because I can tell you that the admissions at the University Hospital all came through our urgent care clinic under control conditions. I mean, we rarely have had a patient come to the emergency ward undiagnosed. So we were able to trace everybody. So I think it's doable, but it takes a lot of effort.
I totally agree with you, Runolfur. I think that the tracing is one of the only possibility that we have. In Italy now, there is a lot of debate about privacy, you know, and so now we should have an app, but the problem is they will tell you, the government will ask to voluntarily download. But, you know, an app works and the tracing works if you have at least more than half of the population that is on the same app. Otherwise, it doesn't work. I mean, if we have 10%, no chances. So, you know, there is a subtle line between, you know, now privacy and the right to defend. So where is now, you know, even, you know, this corona also challenge some ethical rules, because from one side, if we want to protect the overall population, we should provide some of our privacy.
Yeah.
Otherwise, if we want to be totally free, so we will renounce to have a total shelter. So it's difficult, and still there is no answer.
Well, I think, you know, when you have an emergency situation like this, I mean, the government takes over and basically orders people to stay inside their house and so on. Part of that should be to basically override, you know, privacy issues. You know, when you have such a threat in the society.
Yeah, but there is a huge political debate here now.
Sure. And also about strategy, there was a question about how important is massive diagnostic testing on a nation worldwide scale, and are we capable in achieving that?
We started, I mean, we are still far away from a screening, but there is also a problem with the quantification from the analytical side of the quantification of antibodies. At least this is what the technician, what the experts told me. In the sense, we are doing a study in our university that according to the study, you know, you may have IgG, but you don't know whether this IgG can be protective or not, because you must have neutralizing IgG. Then we compare the fast testing, antibody testing with other techniques.
Jeg trykket på et som sto her når jeg prøver å lese hva som står der.
Can you mute?
Can you mute?
Okay, probably I got it.
So it's still difficult to understand, but what we need, at least what we would like to have here in Italy, is a population screening when you at least have 10,000 people screened and you start doing some tests, even for the quality. Otherwise, we will never go out from this cul-de-sac.
Yeah, I agree.
So there was also a question that I guess it's very important for all the discussion, and is about the role and the support from primary care. Do you consider it as being crucial, or maybe it will be in the next phases if the lockdown will be implemented?
Well, based on our experience, you know, early on primary care was involved, but it was not really well organized. So when we got the responsibility to organize the services for the entire country, we included primary care around the country, and we had regular, you know, meetings, online meetings with them. And I think the key issue, you have to give somebody the responsibility to organize the, you know, the care of these individuals and the measures, because otherwise, you know, things are being done differently in different places. People get different messages and so on, and it doesn't work for the community.
Yeah, absolutely. I think that the family medicine should be really organized in order to respond and to reduce the pressure on the hospital.
There's also another interesting question, and is about if symptoms. Yeah, sorry.
I want to ask Nicola,
Sorry,
how
sure.
to explain the high number of physicians that died in Italy regarding the nurses. We have much more nurses than physicians. So how do you explain this discrepancy?
I don't really know. As I told you, you know, half of our dead physicians were family medicine physicians. So they really, you know, they were exposed to a very strong.
But then you have.
I don't know how to explain the fact that, or let's say one hypothesis is our physician population has a quite high average age, while on the contrary, our nurses personnel has a quite low. For instance, in my ward, I have 5 nurses infected, but they were between, you know, 25 and 35 years old. They got normal flu. You know, they were paucisymptomatic, mildly symptomatic, that's it. So this can be, while the family physician who died were all above 60. So maybe there is a different age factor, but I don't know.
So the question I was trying to make was about persisting symptoms after 3-4 weeks of disease with positive lab tests for acute reactants, but patients still feel shortness of breath, intense fatigue, myalgias, arthralgias, or cephalea. So what do you recommend in these cases?
But in hospitalized patients?
I guess so. I mean, I guess so, but it's something also that we are experiencing, to tell the truth, to be truth. So that are patients recovering, but still with some scarring in the lung, for instance. Or
yeah, I have friends that I have a good friend that just called me before the meeting, and he is an internist. He got a mild pneumonia, but after 4 weeks, he still has F40 dyspnea, is very fatigued after, let's say, a small, effort after 200 meters. Is not doing anything, is not, if not waiting, is at home. Is recovering very slowly. The recovery is quite slow.
Well, here's a case where you might think about a complication like pulmonary embolism.
Yeah. I would check deficiencies, natural B1 deficiency, B12 deficiency, iron deficiency that can explain the myopathy, folic acid deficiency.
Oh yeah, there are many, many factors that affect this, but they recover, but it is a very slow recovery.
Yeah, I know.
Slow recovery. Some, for instance, I mean, this is, I can tell you, is not part of my digital. I got infected. I was symptomatic for 10 days, 5 days with fever, other 5 days with no fever, but just congestion, some cough. I've been asymptomatic for 20 days so far, but still my swab is positive. So it's a very long journey.
Yeah.
Very long journey.
We have had the same experience with several cases, but I guess, I mean, this virus is obviously quite virulent, and the same applies to influenza even. I mean, those who get bad bouts of influenza, they sometimes take a long time to recover.
I saw a question now about thrombocytosis in recovering patients, and we have a few of them in my ward that were reported to me with thrombocytosis. And we think that is still a part of the reaction, and so we treated with the corticosteroids, small doses. Yeah.
So I will close with the last question, if you agree.
Yeah, because it's...
But there are plenty of questions, so I warmly invite all people to also to join the next webinar on Monday. So the last question, and I will close with it, it's what about reinfection?
About what?
Reinfection. So,
well, I have doubts about that. We are now in collaboration with the Genetic Institute. I mean, we are retesting people repeatedly after they recover, and we find genetic material in some of these cases, a positive test. But what does that mean? We usually, well, our strategy is that we have people in isolation for 7 days after they become asymptomatic. I forgot to mention that. So it's a pretty robust strategy. Still, we can find positive tests in some cases, but nobody knows what that means, because I mean, is it an intact virus? Maybe even probably not. Is it infective? Nobody knows. I don't think so.
I don't have I don't have any experience with the reinfection, because we have just discharged those who were infected the first time. there were few reports from South Korea, from China, about the possibility to get reinfected, but still, I don't know what to say. We have not seen yet any reinfection.
I don't believe in it. I mean, what I was trying to point out is that some people, they get symptoms again, and they still have the genetic material of the virus, you know.
I agree. I mean,
I totally agree, Runolfur. We don't know what the meaning of this. It's false positive, false negative. We don't know. Until we will have the serological tests, we won't know.
Good.
So, thank you all for sharing your valuable experience. I would like also to thank all the participants. They make lots of questions. Unfortunately, it was not possible to answer all, but Nicola, Runolfur, and Dror, I will invite also people, if you allow me, to the next one. We will be next Monday. And thank you all for this nice afternoon together.
Thank you very much to all the attendees. Thank you very much.
Thank you all.
Thank you, Aneta, also, for organizing all this.
Bye.
Bye.
Bye.